everyone. I am Dr. Mythri Shankar, Assistant Professor in Nephrology at Institute of Nephrology, Bangalore. At the outset, I would like to thank Kidney Warriors Foundation, Indian Medical Association, Indian Society of Nephrology and NephroPlus for having me here. So one common topic that connects the general public, the general practitioners, the general physicians, nephrologists and cardiologists is hypertension. So mostly we'll be talking about hypertension in this panel discussion. When we say hypertension, everybody is interested to know that magic number. What is the normal blood pressure? Can we have the PowerPoint? Yeah, you can just play. How do I play it? Yeah. So everyone is interested in knowing that magic number, the normal blood pressure. And patients who are hypertensives, who are taking pills, they want to know what is the target that they are supposed to achieve. And to help us or to confuse us, I'm not sure, we have lots of guidelines. We have the American Heart Association guidelines. We have the European Society of Hypertension guidelines. And we have our own Indian guidelines. So this Indian guidelines has been endorsed by Indian Society of Nephrology, Indian Medical Association, and the Cardiology Society of India. They've all come together with the Indian guidelines. So we have a lot of literature out there, a lot of guidelines out there. And there are some similarities between these guidelines, some dissimilarities. So I would like to know from our esteemed panelists today, Dr. Ranjan Shetty, sir, what is your take? Like, which is the guideline that you follow for your patients when you diagnose a patient with hypertension? And also, if a patient is already hypertensive and he's on pills, what is the target that he's supposed to achieve?
Hello. Yeah, I'm happy to be part of this. Thank you, organizers. Thank you, Dr. Sundar, for personally inviting me here. I think it's a very valid question because every time there's a new number which comes up, and and there is usually reversal. If you look at JNC, which has been this from JNC 4 to JNC 8, there's sometime reversal which happens. Different numbers, which makes literally 1/3 of the world more hypertensive because the numbers mean a lot. So in my opinion, these numbers are almost the same. The reason why I say that is the more recent guideline talk about home BP monitoring, whereas the older guideline would talk about office BP. By office BP, you mean hospital BP. So if you look at them, there is almost always a 10 millimeter difference between a home BP reading and office BP reading. And that's why the guidelines vary to some extent. Nowadays, all of us believe BP can only be measured at home, not in hospital. The reason being is most of us spend 1 minute, 2 minutes on our patient almost at the same time as by the previous diabetic recommendation. Somebody is going to take their sugar, somebody is poking here, one more person is measuring blood pressure, the patient is talking to you, patient is talking to everybody, and there's a big explanation which comes from the patient. It was normal, but I climbed up, I climbed down, I just had a coffee, tea, and it was okay yesterday without knowing what is okay. So almost all our patients, what we advise is the BP measurement should be at home, not at hospital. All of you know white coat effect, 23% of white coat effect. There's also one more entity called masked hypertension. That means the hospital BP is normal, but the home BP is abnormal. I blame the spouse for it, but that is what it is. It is a known entity, and 10% have this. So that means if you're actually missing 30-40%, if you measure just in hospital, forget the erroneous measurement. I'm talking about a proper, in time, 10-minute gap, sitting without, like in a perfect posture, using an electronic machine and measuring, that's what we recommend. So it has to be home BP reading. If you do home BP reading, reasonable cutoff across the guideline would be 130 and 85. It's not 140-90, it's 130-85. So that is what we should, target, and that's what we should recommend. Lower than that is preferable, although all of you know about the J, it's preferable, but that should not be achieved by drugs. It should be by lifestyle. So when patients are on drugs or when we have to treat it, it's preferable that the number is less than 130-85. And if it is in hospital, 140-90 is an acceptable number. But ideally, hospital BP should be completely discouraged. So what I've done is I have stopped checking BP in my practice, And I've also, when sisters check outside, it's always 130/80. I never trust 130/80. You go for rounds in ward, any BP 130/80 and heart rate 72 is not correct. It's always wrong. It's because they're thinking something when they're measuring the BP. So it's wrong. So it's better to shift to electronic machines. At least they don't give this kind of number. But after rest, after this. But yes, the key thing for all of us is to define the disease before we start treating it. I feel this is an acceptable definition.
So as nephrologists for chronic kidney disease, we have the KDIGO guidelines, which was released in 2021. And for patients with hypertension and chronic kidney disease with proteinuria, without proteinuria, we target a blood pressure of, systolic blood pressure of 120. Moving on, next question is to Dr. Venkatesh sir. So all major blood pressure guidelines emphasize on this standardized clinic blood pressure monitoring or blood measurement technique. So for the sake of everyone, I'll just go through what is this standardized blood pressure checkup. So we need a questionnaire, we need a checklist for it. First thing is we have to properly prepare the patient. The patient should be relaxed. He should be sitting on a chair, feet on the floor, back supported for more than 5 minutes, and patient should have avoided caffeine or exercise for more than 30 minutes. Ensure that the patient has emptied his or her bladder, and neither the patient nor the observer should be talking when you're checking the blood pressure. Most of them we see they're always on the phone, so that should not be happening. And also the blood pressure measurement device, that should be properly validated and calibrated. The cuff should be of proper size. The cuff size should not be too large or too small, and the patient's arms should be supported. So at the first visit, we have to record on both the arms, and in the subsequent visit, we take the higher reading. Also, we have to take minimum of 2 recordings and average that, or if we can do more than 2, even that is better. And each recording should be within a time gap of 1 to 2 minutes. So this is standardized office blood pressure measurement. I work in a government setup, in a government hospital, and we have 250 outpatient visits per day. And we are running short of nursing staff. Most of them are resigning. And we are running short of doctors. We don't have adequate infrastructure. It is practically not feasible for us in a government setup to follow standardized blood pressure measurement in our setup. So how is it in your busy OPD, Dr. Venkatesh sir? Do you follow this, or do you advise that all of us should religiously follow standardized blood pressure monitoring in an office?
It's not possible. Thank you for calling me here for this. But the first session was wonderful. I think the speakers spoke so well. The questions were such a delight to hear, and the answers were very educative. But then, as Dr. Ranjan, I share his feelings about office BP monitoring. Invariably, the readings are wrong. For a long time, I used to take blood pressure myself. I would finish the patient interview. Somewhere after about 5-10 minutes, when into the conversation, I used to take blood pressure. But we see this often, that as soon as the patient comes, we try to take blood pressure. And there are all these, the patient has fought with the reception because OPDs are running late, or they came running, they had coffee, they were speaking to someone, there are arguments. And then the blood pressure is just measured once, and that time you don't give those, all the guidelines are not followed. So the nurses who measure outside, we really do not know. Mercury machines are out of most hospitals now. The ones which are being used today in practices, I think they should be thrown, because it is costlier for mercury apparatuses to be calibrated than buying a new apparatus. There is nobody who is calibrating. And also, most of us don't send our loan apparatus to calibrate. Mercury has leakages, the cuffs are broken, so many problems are there. So office BP measurements are very difficult. People have this doubt about whether the electronic apparatuses are accurate. Many people don't trust it because it keeps showing different values each time. It shows readings like 173/91. No one ever heard of these kind of readings. But I keep telling my patients that 4 million miles away, a 4-kilometer asteroid, a 4-meter probe was landed by scientists. So I think the scientists have done a good job in creating a simple instrument. I think we should educate patients to check. The apparatuses are not expensive at all. All the conditions, the mind and body to be calm, no caffeine or food for the last hour, and no fight with anybody. These conditions can be easily fulfilled at home, and I personally believe the same pressures which you have, time, whether it is in a government institute or a private institute, because people don't want to wait outside. The next patient is already fighting with the reception to get in. So therefore, unless it is really important, it happens sometimes. So what I do is, if my trust in the blood pressure machine or the patient's recording is not good, I send them to a recovery room where the patient can sit for some time, and one of my nurses can check on the monitor of the electronic monitor. So that would be the way I cross-check. But uniformly, we are telling now people to don't worry about what you record in the hospital. Please record your blood pressure at home.
So when a patient comes to us and you diagnose patient with hypertension for the first time, obviously we need to do some tests to find out whether it is primary hypertension or secondary hypertension, and also we look into investigations to see if the complication of hypertension has already occurred. So what are the routine set of investigations that you order for a patient who is diagnosed with hypertension for the first time in your OPD?
So first off, when the patient has stage 2 hypertension, very high blood pressures, then we label them and possibly even start treatment early if blood pressures are very high. Otherwise, stage 1 hypertension, pre-hypertension, give a time period of about 2 to 6 months to monitor, record the blood pressure, come back whether they really are hypertensive. In that interim, what are the tests which are done? A urine analysis. I think it's a very, very underused tool. Many of us order urine tests, but we really don't look at it carefully. Proteinuria and hematuria are easily missed, also neglected. For instance, in young hypertensives, we all know that Burgess disease or IgA nephropathy is such a common cause of later kidney disease evolving, but that microscopic hematuria is generally ignored and not followed up. So therefore, we miss a lot of potential kidney disease patients, since this is a Kidney Warriors Forum, I'm specifically mentioning that. But urine analysis, serum electrolytes, Dr. Anjan was mentioning in the morning that Conn's syndrome is primary aldosteronism is missed, because as soon as a patient is seen, many of us start them on ACE inhibitors or ARBs, and we miss the diagnosis of potassium abnormalities. So serum electrolytes, serum creatinine, and then HbA1c, and then lipid profile. In addition, two important things which are not very emphasized are ankle brachial index, the blood pressure difference between the arm and the leg, because peripheral artery disease is missed frequently because of this. Many of our diabetic hypertensives suffer from peripheral artery disease. And weight, we do not measure weight many times, and it's a very important parameter. One emphasis on serum creatinine, I think, is not really justified. Today morning I was just looking up my profile. My serum creatinine is 1.1. I'm 72 kilos. I'm 170 centimeters. And I realized my EGFR, choreographed formula, is 80. It's not normal. For a man, the EGFR should be more than 100. So, but we don't use this simple parameter. It has its problems. I do understand EGFR measurements have their own problems. But in a majority of cases, we just look at a creatinine of 1.2, 1.3 in our OPDs and say, Parvagila. And that, I think, we end up missing a lot of these. So in addition to urine analysis and serum creatinine, a simple online formula to measure the EGFR, lipid profile, screening for diabetes should be done. And in very severe hypertension, we don't do this, all of us don't do this regularly. In PGI, when we were students, ophthalmoscope was mandatory and we were looking at everybody's funduses. We don't do that anymore in our busy practices, but I think in severe hypertension at least, we should send the patients for fundoscopic examination.
To add to this, we have the National Kidney Foundation app. It is available online. You can download it on your smartphone. All you have to do is just to enter your creatinine, your age, and your gender, and that will calculate the EGFR for you. So that is what we use for bedside EGFR calculation, estimated EGFR calculation for all our patients. Moving on to the next question to Dr. Ranjan Shetty sir, and also probably our patient representative can answer this. It becomes our responsibility to explain to the patient why we are getting all these set of investigations when he's diagnosed with hypertension, and also we have to explain to the patient regarding the adverse effects of the drug. We have to counsel the patient regarding follow-up. Most of them, we start them on medications, but they are lost for follow-up. They don't come back because they don't know the importance of follow-up. So in a busy OPD, how do we go about counseling the patient regarding the adverse effects of the drug, the importance of follow-up, and also the complications of hypertension? What will happen if you don't come for follow-up, if you don't maintain your blood pressure in that appropriate goal range? So that the counseling becomes very important to motivate the patient to maintain the blood pressure at that particular level. So how do we go about counseling patients in a busy OPD? Is there any role for physician assistant or a dedicated counselor for this?
Thank you. And I think it's a very important question because most cardiologists end up seeing 30 to 40% of our OPD is actually hypertension. And we probably spend more time on hypertension than counseling patient for angiogram for who need it, because they have a lot more question. It's a lifestyle disease. That is what we should understand, and there is huge role for how we talk, what we talk. One very important thing what we do is, at age of 50, 55, 90% become hypertensive. That is first thing we need to tell people, that you cannot probably fight it out. It's very likely that at some point in your life, all of us will become hypertensive. So that fear and anxiety is gone. I even tell them, better to be with the majority than minority, when you reach that. So hypertension is something. So you can escape diabetes because there is a lot of genetic tendencies, but hypertension escape is probably not possible, and it's something which we need to accept. So when you say that, it's not the drugs which are problem, it's the disease which is problem, which is also important for us to tell to them that why are we treating hypertension? Are we treating a number or are we treating a complication? It's important to tell them that, we are treating mainly to prevent a stroke, because 80 to 90% of stroke, prevent kidney disease, prevent heart failure rather than heart attack. The disease list is long, and it's very important for us to make them understand, because every patient jumps up and asks about side effect. Any drug you want to start, you start side effect. So typically what happens is, especially with those borderline stage 1, 150, 160 BPs, I don't start in the first visit at all. I have a printed sheet which is 2-page, 1 page explaining the page. I give it to almost all my patients. 1 page explaining what diet, about DASH diet, the exercise, the weight loss, these kind of things. The second page actually clearly mentions how to measure BP at home, where I strongly recommend you lie down for 10 minutes, then check. That means 1 BP measure, because there is 1 minute gap. So 1 BP measurement is a 15 minutes job, and it's important. I even tell it's better if you don't see, someone else checks for you, doesn't even tell you the number, average it. We tend to give a lot of work. When you do this for a month, and when patient actually thinks and they know that you're not trying to put a drug, you're trying to talk to them, you're trying to get the disease under control and make them understand it. I feel it works well, because I see most of these 4 to 6 weeks later with the BP chart. By this time it has sunk in to them that they could be having hypertension, and it is not the drugs which are dangerous. Meanwhile, as Dr. Venkatesh said, those blood tests are ready. You're not again rushing them to do all the tests just because they come. Most of us tell that when you come back next time, check these blood report and come. So with that, when they come, they have done their lifestyle, they have tried to lose 4 to 5 kg, whether it is possible or no. Target is only 1 kg per week, it's not that difficult for anybody. So 4 to 5 kg, when you come back, it works well. Some of them take it extremely seriously and they do get their blood pressure down, and that's good. And you don't need to worry, especially if the ECG doesn't show LVH. If there are no other major parameter, it is okay by the time the reports are ready. So it's important we spend. Next time when they come, they do ask some of those questions. Then the first thing I ask, did you get this sheet? which I have. I tend to give one more sheet because we have written, because this has been a major problem. So I have 4 or 5 sheets in just behind. One is diet for heart patient. One is on HCM, because again I see 3-4 HCM, hypertrophic cardiomyopathy a day. It's important they understand and they come back. Most people are quite literate, or there is somebody who can read English in their family, and they work. The other important thing, once we do, probably, I don't know, the important thing, the most common secondary hypertension now is actually obstructive sleep apnea. 60% is obstructive sleep apnea. It's not, whatever we said, it's not pheochromocytoma, however fancy it looks. The chance of us finding a pheochromocytoma in our lifetime is mostly 4 or 5 patients. But every other patient of a resistant hypertension is actually obstructive sleep apnea. So that history we should always ask and take, because unless you manage that, and these are the ones who come with very high BP and it's very, very common. And for some reason, say I've practiced in Manipal, Udupi, and I've practiced here, the phenotype is different. For some reason, Bangalore is a hub for obstructive sleep apnea, but the acceptance is higher here. When you tell people that you could be having obstructive sleep apnea, they accept, and some of them actually are already on CPAP mission. So I think it's very, very important. Rather than looking at fancy things, it's important. 2 important diseases when the BP is not controlled is either renal, some sort of a kidney disease where creatinine is slightly above normal, maybe 1.5, maybe 1.6, but it's definitely not normal, and obstructive sleep apnea. You tackle this, 90% of your patients are actually tackled.
I would like to ask our patient representative, what was your experience with the counseling and how important is counseling?
Yeah, for me, when I was 14 years old, I was diagnosed, and luckily I went for insurance, and I was not underqualified because 18 years was a private age. So I had to go undergo medical investigation. And that time when I saw, it was, doctor saw my BP, it was 200 by 90, and he was shocked. And then that's the investigation started. So eventually doctor talked about why, your early aging, and they started to do a lot of investigations, and then slowly and gradually the creatine was on a borderline, as doctor said. But then I was on medication for almost 10 years or so the creatine was unstable and all that. But eventually I would say that uncontrolled hypertension, that started decaying my kidneys, I feel so, I'm not sure what, because then the kidney was shrunken and we were not able to do biopsy and identify what exactly went wrong. But yeah, but doctor, as he said, couple of things helped me to prolong. One is the salt intake in my diet, exercise, that would also help me a bit. And third thing, follow up and medicines on time. That 3 things which would help a doctor counseling, it helped me. But unfortunately, as I said, so I directed early age, and it went for a prolong, and then I'm 36 now. So 2 years back, both the kidneys had failed, and I had undergone a kidney transplant. Luckily, my wife donated me, and now again back to the journey. As the doctor said, I have a home monitor. I start monitoring it, and continuing it. What the doctor is saying.
Can I add one point? Very common problem that comes is, especially in stage 1 hypertension, borderline pressures, when we realize that the patient has to take medicines, the common question is, I don't want to start medicines because I'll get habituated to this. This, I think, is a very, very common bugbear which doctors who treat hypertension have. Now, I keep giving an example of a clothesline that it's hanging there, and you pull it down with your hand, and the moment you leave it, it goes back again. So it's not that your clothesline got habituated to your hand, or it would be easier for you to say that I don't want to eat food, because if I don't eat food, then I start feeling hungry. This is a disease likely to stay with you. There are chances that if you correct some reversible causes like sleep apnea, alcohol, which has become very common now, you may be able to get rid of hypertension. but that needs a lot of dedication. 5% of patients with primary hypertension may be eventually able to get off, but you must convince yourself before you start treatment that you are going to be there with these drugs for life, and they are safe. These drugs are made for patients to take it for decades. So if you have this myth built into your mind that once you start taking medicines, you get habituated, you're harming yourself. As Dr. Ranjan said, we are not treating a number, we are trying to prevent complications. I think this counseling, this part of the counseling where why do you have to take medicines and that you are not getting used to the medication, but you are trying to protect yourself from complications. I think this part of the counseling should be the most extensive when we are talking to patients.
Maybe Ranjan Shetty sir can share his templates with all of us to save time.
So, what would the ideal age for monitoring BP? I mean, because now we see around me, myself, my colleagues, my cousin, in fact, she has hypertension. She's just 28 years old. And do we have any age criteria to check when, a parameter as such that?
So I think this is a very important question because, younger people, when they come, they're very scared, and why? So as I told, by 50, 90% will become hypertensive, but it doesn't happen on 50th birthday. It starts much earlier. If you look at, we did a school health study long back, and the school health study actually showed 4% of high school students were already hypertensive, because now even obesity is much common. So it keeps on adding. So some of them get little early, some of them get little late. So that's what we need to, and escaping it, once you realize that you probably cannot, it's like age. All of us want to remain young, but it's just not possible. Age will catch up. So similarly, it's very likely that hypertension would catch up. I mean, this message, once it reaches, people accept it. Now, when to test? Any time, every time which is possible, you should test. I remember my professor who would say, people come for diarrhea, check. People come for fever, you check. The only thing what a doctor should do is check BP properly. Now, yes, there are difficulties when you check, but whether it is a youngster or whether it is the older person, I think whenever they come to a doctor, they should check. At home also, we need to encourage people to check. Now that probably at least one person in a house is definitely hypertensive, it's just not possible to escape that. Even others should check. When they are fine, once in 6 months they could check, or once in a year they could check. Also, to just add on what Dr. Venkatesh said, sometimes it's possible to control it with loss of weight and exercise, but that's the lifestyle they have to maintain. I have people, 2 years back they were better, they come after 2 years, now the BP is again high. So if you control by lifestyle, it's important that you maintain that lifestyle. You can't forget it. And that's the most difficult. If you look at any dietary studies or exercise studies, the people who follow it after 6 months, after 1 year, is very low. It's less than 50%. 2 months anybody can follow. But checking BP, any opportunity to check BP should be utilized. Rather, we should ideally have hypertension booths in malls and airports. They do that sometime, and it's important for people to check it anywhere.
For nephrologists, hypertension and chronic kidney disease, both of them are like husband and wife. They come together. That is difficult to answer. So we see chronic kidney disease patients, 80% of them are hypertensive, and it is almost universal in dialysis patients. It is more than 90%. And also kidney disease is considered as a cause or the effect of hypertension. The debate is still on. Which came first? No one knows. The debate is still on, whether the chicken or the egg. So for you as cardiologists, you see so many patients with hypertension. What percentage of them have kidney dysfunction at the time of diagnosis of hypertension, and what percentage of patients go on to develop kidney dysfunction who did not have kidney dysfunction at presentation?
I think it's a mix of patients we see at least in tertiary care OPDs. We have patients with kidney disease coming with hypertension. We have just diagnosed hypertensives coming in. Dr. Arvind showed some figures. I think about a third of our patients are hypertensive. A small percentage are I think, kidney disease. I don't think we can really put a number onto that, but I guess if you take a general mix of all patients, maybe about 5 to 10% of patients have some kind of kidney disease. As I said, again, we don't pay enough attention to urine analysis. There may be some proteinuria, we just brush it off, some hematuria, we brush it off. and we don't calculate EGFR. If we look at this, potentially a larger number of patients with hypertension may have incipient or very early kidney disease which they develop. And to address Dr. Sundar's joke question, that who is the wife, who is the husband, I strongly believe hypertension is the wife. Because like all patriarchal societies, once a patient develops early kidney disease, we tend to ignore hypertension. And it is sad to see, actually, in patients with early kidney disease due to diabetic nephropathy, we pay so much attention to sugar control. And also for patients with heart disease, we pay so much attention to diabetes control. Diabetes is an important disease, no doubt about it. But by the time a patient develops early kidney disease or a heart disease, the diabetes story is over. There is no need to control diabetes either. In fact, very aggressive control of diabetes in patients with kidney disease, elderly patients with heart disease can actually be detrimental because it can cause hypoglycemia and its complications. It is extremely important in early kidney disease and patients with heart failure to control blood pressure, much, much more important than controlling diabetes, because diabetes has already caused the complications that it has gone. It is not going to cause any more problems, but at the time we pay more attention to the wife. We give her all the love. We give her all attention by gifts, medicines, monitors, whatever can be done, make it stress-free. I think that's going to pay that family a long run, because CKD is a devastating disease. We all know that families get ruined by people, especially those who pay out of pocket. So I think we should very carefully look at early kidney disease in patients with hypertension, and we should follow that up. We should actually treat hypertension much, much more aggressively. Enhance surveys have shown that nearly half of the patients with hypertension in a community are not even picked up. And out of those who are diagnosed, 1/3 get any treatment. About 25% get well controlled. So it's a huge gap, and it's a low-hanging fruit. As Dr. Ranjan said, any opportunity to measure blood pressure. As a physician, I think the most important service we can do, when a person comes with a bunch of reports, some of the reports run to hundreds of pages saying that I got an annual health check, I just keep it to the side and say, did anybody check your blood pressure? And those are the patients who require that. Somebody comes for a fever, somebody comes for a urine infection, anything. I think the most important service a physician can do is to check blood pressure. There are errors, but then at least we kind of make an awareness, and also if there is a hypertension, it is picked up. Families having blood pressure. How many of your patients have come and said, I went to a friend's house, he had a BP apparatus, I checked, incidentally found myself to have BP of 200/100. I think all of us have experiences like this. So I think checking blood pressure is very important, and these are the patients who require monitoring of their kidney diseases, especially younger ones. We have a live story here. So many glomerular diseases, renovascular diseases, IgA nephropathy is easily missed, until advanced kidney disease comes, and after that we don't even know why it happened. So I think it's very important to screen for kidney diseases, especially in younger lot.
We are coming, we have just 5 minutes left, so any questions from the audience?
If the BP is, the cutoffs we already discussed, around 161 reading is okay. So what we do to these patients is we check whether the ECG or echo has left ventricular hypertrophy, LVH, what we call as. If the heart is already responding to it, like any other muscle, heart becomes thick. Your biceps becoming thick is good, but heart becoming thick, not so good, because it is adverse reaction. And these are the people who are likely to go into kidney failure because your organs are not taking well. The same patient, if there is no LVH, no organ symptom, there is nothing, we could wait for 4 weeks. 4 weeks, 6 weeks is not a big deal when you're treating hypertension in an asymptomatic individual. Somebody who is perfectly fine, only problem is you picked up the BP for him, don't panic. Even if the number is 180, 200, do not panic, okay? But So I think the trick here is to make sure that patient understands it's a disease and not a number. Like Dr. Venkatesh said, better to wait, don't be in hurry to start any tablet, don't tell them it is for 2 weeks, 3 weeks, 2 months, so that, so that people stop it after that. Most people come and tell when they come a year later, doctor gave me for a month. There is no, no doctor would do that, but there is no, they take what they want to take, hence they stop at that time and come with a much higher BP or complication.
The last question, madam.
Yeah. Most of the hypertensives are on ACE inhibitors or ARBs. Do you prefer one over the other? Because we need cardioprotection and nephroprotection for these patients. Is there a preference?
I think the ABCD rule that younger patients get some drugs and older patients get some drug holds. Predominantly systolic hypertension in very old people, they respond very well to calcium channel blockers. But as you said rightly, a lot of patients are on ACE inhibitors or on ARBs. Worldwide and in India, ARBs are the #1 drugs used for hypertension. I guess if you actually look at the literature, there is very marginal difference between ARBs and ACE inhibitors as far as nephroprotection is concerned. Of course, the nephrologists are. Yeah, I'm talking about efficacy in protecting the kidneys. I think the difference is marginal, and cough is a very irritating, and also a lot of marketing has gone in, so therefore ARBs are used extensively. I think they are a good class of drugs. As far as heart is concerned, ACE inhibitors are better, and nowadays with patients with low ejection fraction, an ARB with a neprilysin inhibitor, what is called as ARNI, has come in as a #1 choice for us. But otherwise, there is not really much to choose between ARBs and ACE inhibitors when it comes to hypertension. It's easier to use an ARB because patients don't come back with cough as a complication, but rest of it is technically the same. Combination, I've seen combination of AC and ARB. It's detrimental, and I think is not advocated anymore to use a combination of both of these drugs.
So the key take-home message.
Yes, just to add, Dr. Venkatesh has covered everything, but the valid around 2009, 2010, there was a big concept of what is known as ARB-MI paradox. It was believed that if you give ARB, there will be more heart attacks, and most cardiologists at that time, we were actually worried, and we wished to be a strong proponent of ACE. I'm talking only about hypertension, not about LV dysfunction and others, and nephrologists to be a bigger proponent of ARB, and that's where probably people were worried. But over the period, the newer ARBs are longer acting, they are more efficacious. See, if you look at HOPE trial, Ramipril reduced BP by 5/3. Which will not be picked up in your routine practice. Who looks at 5 and 3? No, you want to look at 10 and 20, not 5 and 3. So whenever the BP is higher, like more than 150, 160, chance of AS controlling it is much lesser compared to ARB controlling it, because they are much more stronger, they are likely to act. And over the years, over the decades, our worry about ARB-MI paradox has come down, because the recent trials like On Target and others have not really shown it. So nowadays, most hypertensives end up getting ARB for this reason, because it's more potent and we are not worried about the adverse effect on heart. But yes, if the BP is little lower, ACE will definitely be having more data, and it will probably be a better antihypertensive for a BP which is 140, 150. But anything beyond 160, it's not going to work enough.
So the key take-home message, both hypertension and chronic kidney disease are silent killers. They are silent disease. We have seen in our own setup in our government hospital, most of the patients land to us in CKD stage 5. That is the last stage. That is when they start developing symptoms. So that is when they come to us. 60% of them come to us in stage 5, and there's nothing much that we can do at that point of time other than providing them dialysis. So the awareness is also very low. When compared to cardiovascular disease or malignancy. Everybody knows about 2D echo, everybody knows about PET scan, but nobody is interested in getting serum creatinine and urine routine, which hardly costs less than 300 rupees. I don't blame them, it is the awareness. The awareness is not much for kidney disease. Even my own relatives, my husband is a cardiologist. My own relatives, they call me and they're like, can you get an appointment with your husband? I'm traveling to US next year. I want to get my heart checkup done. But what about your kidneys? Come on, you're calling me. So at least just make sure that you get your serum creatinine and urine routine for all of your patients. That will be very helpful, because if you pick up the disease earlier, they will not have any symptoms in CKD stage 1 and stage 2. Now we have lot of drugs like SGLT2 inhibitors, ACE inhibitors, ARBs. We can retard the progression of the disease, like what Dr. Gurudev sir was telling. And Dr. Arvind sir was also emphasizing on. So it is best if you could help us in picking up the disease much earlier, because the patients come to nephrologists only when they develop